Uh, Good afternoon, colleagues. We start off another week of sessions under the series Learn from the Masters. Today we have Dr. Meena, who heads our glaucoma services at Sankara Hospital, Bangalore, who's going to be sharing with us insights on glaucoma drainage devices. Over to you, Dr. Meena.
Thank you, Dr. Kaushik. Good afternoon, one and all. So we'll discuss about glaucoma drainage implants today. So this presentation I have tweaked it mainly for the postgraduates. As far as fellows are concerned, probably they should go in a little more in detail about evidence-based insight into the glaucoma drainage implants. So Kaushik, are you there?
Yeah, I'm there.
My slides are not moving. Yep. So this is the overview of our presentations today. So we'll give some introduction and the types, the pathophysiology, the indications of doing this surgery, and preoperative evaluation and surgical steps and complications. Now, moving on to a little bit of history. So it dates back to 1907, wherein Rowlett and Moreau started with the horsehair through the cornea to treat the patients. Then it moved to 1912, wherein Zohar had started using a silk thread. In 1969, it was a landmark invention by the Molteno, wherein he explained the pathways of bleb resistant and designed a tube. So Krupin, again, in 1976, he came out with a unidirectional valve, which provided good resistance to the aqueous. And again, another landmark was in 1992, wherein Barwell introduced a non-valved silicon tube, which is attached to a large barium impregnated plate. Dr. Matan AHMED introduced his AHMED glaucoma valve, which most of us are very familiar with, in 1993, in which he used a pressure-sensitive unidirectional valve. And of course, in 2013, Indian version of a Barwell implant was introduced by Orolab Aqueous drainage implant. Now, glaucoma drainage devices, basically it creates an alternate aqueous pathway from the anterior chamber to the subconjunctival bleb or the suprachoroidal space, channeling the aqueous out through the tube. Now, when we divide these drainage devices, it can be divided into setons, the stents, and valved or non-valved implants. Now, basically, the setons or the bristles are totally out of vogue now. When stents, it's basically a tubular structure wherein the fluid passes passively. When it's valved or non-valved implants, there is a tubular structure for unidirectional or a controlled flow. Now, the glaucoma drainage, among the glaucoma drainage devices, when we talk about the stents, I've just listed out the stents which are in use now. Probably the CYPAS has not been given an FDA approval, but I'm not going into the details of these stents, probably because this becomes a too long a presentation. So I'm skipping the stents details here in this today's presentation. Now, when it comes to implant designs, it can be studied under basically a type of plate, type of material, or depending upon the type of the opening. Now, it can be either a rigid or a flexible plate. Usually, flexible plates are known to cause less inflammation. When it comes to material, Barwell, Krupin, and AHMED, they have silicon materials, and again, AHMED has both polypropylene version also, and Molteno is also made by polypropylene. Other materials which are being used are hydroxyapatite and expandable polytetrafluoroethylene. Now, we can divide these implant devices based on the type of opening. Here you can see this is a single plate Molteno implant. This is a Barwell implant, and this is a RD, which is in vogue now. And coming to the valved implants, this is a Krupin valve, and this is a AHMED glaucoma valve, which most of us are familiar with. Now, what is the pathophysiology behind these glaucoma drainage devices? So basically a fibrous capsule which is formed around the end plate, which involves many beaks, and the aqueous plate and the surrounding non-adherent fibrous capsule. So what happens is this aqueous passes through these capsule by passive diffusion and is absorbed by periocular capillaries and lymphatics. Again, this fibrous capsule around the end plate that forms the major resistance to the aqueous flow through the drainage implants. So we need to understand this pathophysiology whenever we use these kind of implants. Now, this was a landmark study, that is a TVT study, treatment outcomes of tube versus trabeculectomy. This gave us a lot of insight into the usage of glaucoma drainage devices. So basically, the purpose of this study was to compare study the efficacy of non-valve tube shunt. In this study, they have used a 350 millimeter squared bare-well glaucoma implant to trabeculectomy with mitomycin in patients with previous ocular surgery. So they had brought out these results in 2012 in American Journal after 5 years of the study. So what are the major observations of this study? So they found that it was a comparable result to the trabeculectomy with MMC, and both the surgeries, that is the tube shunt surgery and the trabeculectomy, gave a very good effective lowering of IOP. Again, the trabeculectomy group had a progressive increase in using adjunctive medical therapy during the 5 years of follow-up, and whereas the use of glaucoma medications remained relatively constant in the tube group. So the rate of resurgery was higher in the trabeculectomy group when compared to the tube group. Now, what is the downside of this TVT study? Basically, no data from the TVT study indicated the success rate in the subgroup of patients who had previously failed trabeculectomies. And another thing was, in this study, they have used the bare-well implant throughout the 5 years. So there's no other implant which is being used in this study. But we got a lot of insight to the usage of glaucoma drainage implants. So it's good to know a part of the study. Now, what are the indications of glaucoma drainage implants? This is very important to understand, because usually whenever there is a failed filtering surgery, and when there are chances of high risk of failure of filtering surgery in cases like secondary glaucomas like neovascular glaucoma, uveitic glaucoma, when there has been a previous intraocular surgery, be it a vitreoretinal or a corneal surgery with a lot of conjunctival scarring, which can result in a failure of trabeculectomy. Again, sometimes cyclodestructive procedures may not be possible in certain eyes which has little bit of useful function. We don't want to take a chance of getting into a phthisis bulb. By these patients, we can opt for glaucoma drainage devices. Post-traumatic glaucoma, then congenital and juvenile glaucoma, glaucoma in aphakics and pseudophakics, post-keratoplastic glaucoma, and other secondary glaucomas like ICE syndromes when there is a lot of epithelial downgrowth. Now, what are the contraindications? Malignant glaucoma or ciliary glaucoma is a contraindication to undergo a GDD surgery. These eyes wherein there has been a severe scleral or a scleral limbal thinning, and when there is an extensive fibrosis of conjunctiva, this surgery has to be done with caution. Again, when there is a vitreous in AC, probably we may have to do a vitrectomy before we attempt this surgery. And in eyes where there is a silicone oil already inside the eye, probably we may have to implant it in a different quadrant or an inferotemporal quadrant. So these are the eyes which it is not contraindicated, but certain measures we have to follow before we plan for the surgery. Now, when we plan for the surgery, what are the preoperative checks which you have to do? So when the patient comes to you to your office, we have to make sure that there is a good mobility of the conjunctiva, and we have to identify thinned area of the sclera. This will help us to identify the quadrant on which we have to put the implant. So it's important to use a forceps and understand the mobility and whether there are any thinned areas in any of the quadrants. Of course, we have to look for the corneal endothelium before we plan for the surgery, because when we are putting the tube into the anterior chamber, it should not have a tube endothelial touch, and if there is any progressive loss, then we may have to change the site of the tube. Of course, we have to look for new blood vessels in the iris, because many times we use the surgery for the neovascular glaucoma. So we need to identify whether there are new blood vessels, because as soon as you put the tube, what happens? We can have a bleeding inside the iris, which can create a lot of problem, tube blockage and all that later stage. And depth of the AC, this will decide on whether you're going to put the tube inside the anterior chamber, or you want to put the tube in the ciliary sulcus or in the pars plana. So, and of course, the length status we have to see, because the length of the tube when we are putting the anterior chamber, we should make sure that if it's a phakic eye, we have to make sure that the tube doesn't touch the lens, because that can result in cataract. And of course, we have to do a good gonioscopy findings we should have before we attempt the surgery, because any kind of peripheral anterior syndicate, that area has to be avoided when we introduce the tube. Now, I'm just going to talk about the prototype which most of us use, that is the AHMED glaucoma valve. This is Dr. Martin AHMED who introduced this AHMED glaucoma valve. So if you see here, it has got a medical, it has got a plate which has got a medical grade polypropylene. And this is the drainage tube which is used, which has got a silicon membrane. And this is the valve. Okay, and this is a valve which has got a valve mechanism inside this, which is made up of again silicon, and this is the coverage of this valve. So this AHMED glaucoma valve, it basically it follows the Bernoulli's equation. So as I showed you, a silicon elastomer, there is a membrane which creates a valve venturi shaped chamber. So this, when you put a pretension, the membranes are pretension to open and close in response to the IOP, like in the range of around 8 millimeter, 8 to 10 millimeter, usually these membranes open up. So this follows the Bernoulli's equation. Now the tension in these silicon membranes help us to reduce the hypotony by closing. Once the pressure has reached the pre-tension level, then it closes after the pressure has decreased to the normal level again. So the silicon membrane is the most important part of this AHMED glaucoma valve. Now there are different models of AHMED glaucoma valve which is there. So usual models which we use is FP7 and FP8, which is made up of silicon. Basically FP7 is an adult size which has got a 184 millimeter square, and pediatric size which is 96, that is FP8. Now there is other variety called PC7 and PC8. Basically this is what, there is a guard which when we introduce it to the vitreous, but nowadays almost all the cases, even if it is introduced into the pars plana, I'm using FP7 and FP8. Now the new medical has introduced a new valve which is called as AHMED Clear Path, which is a non-valved one, which is something like a bare welt implant. So that is a newer thing which is they have introduced with their non-valved implants. The same company has introduced. I'll just show you surgical steps in the form of a video. So basically, this is a case of a neovascular glaucoma whose was a one night. In the other eye, I had done a cyclodestructive procedure. So this patient had undergone PRP, and from the retinal end, it was all stable. So basically, this is an eye, this is a virgin conjunctiva. I have no other previous surgery was performed. Here I had used a Mersilk for corneal traction. Nowadays I'm using 60 Vicryl for the corneal traction. This is a slightly older video. So the quadrant which I've chosen is a superotemporal quadrant. So a thorough conjunctival dissection is to be done. Initially I use a conjunctival scissors, and then you can use a tenotomy scissors to get a good pocket of conjunctiva, which is very important when we place the implant. A very generous pocket should be there, otherwise every time the implant, it will be very difficult. So I've cut the conjunctiva here to make sure that I have got enough space and the visibility of the plate is good. Now a good cautery has to be done, because again bleeding will preclude us to see the plate end and to tie it onto the sclera. So this is basically the priming of the tube, which is a must in all cases of valved implants. So I am using, you can use a 27 gauge or a 30 gauge needle, which is blunted at the tip. And this is how you can see the jet of the saline which is injected. So that shows that the valve plate is functional. Now you have to insert the AHMED glaucoma valve into the pocket which you have created. So it is important that the plate end is around 8 millimeter from the limbus. 7.5 to 8 is a good ideal thing, but if you are implanting it on a nasal side, probably a 6 millimeter is good enough. So once you measure around 8 millimeter, you have to anchor this plate onto the, these are the eyelets which you can see on the plate. So you have to anchor the plates onto the sclera. I generally use a 90 nylon to anchor the plate. So I have seen many of us have these challenges of visibility. So because some of the eyes are very, deep eyes. So the visibility is only through corneal traction. You might have to have your assistant to, keep the traction. And this is another important step which we have to follow, that while you are anchoring onto the sclera, this anchor should be good, strong anchoring, and it has to be onto the sclera, because if there is an anterior movement of the plate, if there is, in case of any loose sutures, there can be an anterior migration of the plate, or a posterior migration also can happen. So it is important to tie this suture very well. It should not be a superficial. You should take a good partial thickness sclera to anchor the plate. Now this is the other eyelet. So once you suture this, you can see the through the eyelet, it's a very easy pass. So we should not injure any part of the plate. It should be an easy pass through the eyelet. So once you are tying it, you can tie, put the knot into that eyelet, so that so once we anchor the plate onto the sclera, the next step is to measure the amount of tube to be inserted into the anterior chain, and you have to cut this bevel up. So in this video, I am using a 22 gauge needle and I'm entering into the anterior chamber. Nowadays, I use a scleral tunnel, and then I put the tube through the tunnel into the anterior chamber. And once you are inserting, this is a tube inserter which you saw me using. And once the tube is inserted into the anterior chamber, you can anchor the tube using a 90 nylon. This is important. Again, the micro movement of the tube can result in lot of complications. After that, I'm using a sclera, donor sclera, to cover the tube. You can use a partial thickness donor sclera, or you can use a corneal button also. And then once you do that, you cover the tube, and then followed by a good conjunctival suturing is important. And generally, I don't use any kind of side port. Usually, I don't use. In case I'm suspecting any kind of a silicone oil, I put a side port and wash the silicone oil inside from the anterior chamber. So this is important to have a very watertight closure of the conjunctiva before we bind them. And this is what I practice. Generally, I put like a mattress suture, because this is the area where your tube can get exposed. So I just put a conjunctival mattress suture there to make sure that there is no tube exposure. Now, a little about RD, which is Orolab Aqueous Drainage Implant, or RD. It's a non-valve device. Again, many of my colleagues are using. I have not yet started using this. So it's a non-valve device which was commercially available in India since 2013, and it's very much similar to the Behrwelt glaucoma implant. So he is Dr. Paul Palmberg, who is one of the brain behind this RD implant. And again, its surface area is 350 millimeters square, and its lateral wings are to be positioned under the rectus muscle. So this is a small video about the RD implant. This is, I've taken it from the YouTube, since I personally have not been doing the RD implant. So most of the steps are same. You have to have a conjunctival good thing, and this is the hooking of the muscles. In this particular video, they have used an inferotemporal quadrant. So you have to hook the muscle to make sure that the wings of the RD are well placed behind the rectus muscles. So this is again the priming of the implant. So once the priming is done, the implant is placed. secured under the wings of the rectus muscle. And then again, same way, we have to anchor the implant onto the sclera. There are eyelets again in the RD implant to anchor the plate onto the sclera. Now, the difference is this: since it's a non-valved implant, we have to tie the tube, we have to ligate the tube. So this is the ligature, what they are doing using a Vicryl suture. So which gets around 4 to 6 weeks later, by then it gets opened up. Now this is to make sure that your ligature is good. So you have to inject saline and see whether the ligature is in place. Then this is the end of the cutting of the tube. And then once this is done, the tube is introduced into the anterior chamber. The rest of the steps are same as like an AHMED glaucoma implant. Here they have used a corneal button to close the open part of the tube. So what are the complications in these glaucoma drainage devices? Now, there can be some intraoperative complications. One of the common ones is conjunctival buttonholing. The video which I showed had a virgin conjunctiva. Now, we have had many cases wherein multiple surgeries would have been done. So in these cases, very, very careful conjunctival dissection is mandatory, because conjunctival buttonholing can happen during your dissection. Of course, bleeding. This is especially when the patients are, NVG cases. There can be a bleeding in the anterior chamber, or when you are doing along with the PKP, sometimes there can be bleeding. And depending upon what and length and the position of the tube is again important. So we should make sure that adequate length is cut for the procedure. So sometimes inadvertently you may cut the tube very short. We need to be very, very careful about when we cut the tube. Then scleral perforation, not a very common thing, but this can happen in case of like congenital glaucoma, where there can be a lot of thinning in different parts of the different quadrants. Yes, expulsive hemorrhage, it's not really uncommon to have expulsive hemorrhage, because these patients whom you're going to operate, they might have a lot of uncontrolled intraocular pressure. So it's mandatory to make sure that the pressure is under control. Put an IV line, keep mannitol ready while you're doing the surgery. In case there is any suspicion of expulsive hemorrhage on table, we have to act upon immediately. So keep the mannitol ready. What are the early post-operative complications which you can see in this GDD? So one important complication is hypotony. So I've just listed out these complications. This is how you should write in the exam when they ask in theory, like hypotony, hyphema, wound leak. There can be tube occlusion, Delin, malignant glaucoma, and hypertensive phase. We'll just go into a little bit detail of these post-operative complications. How do you avoid it, and how do we manage these complications? So the hypotony, it is because of a poor flow control. So hypotony can result in shallow anterior chamber, and this shallow anterior chamber may change the position of the tube, which is again a problem. So if you see this flow chart, you can see the anterior chamber, it can still be formed even there is a hypotony. If there is no complication, we don't have to do anything, just wait and watch. If there is if you can review it, and then if there is a maculopathy, if you are seeing a maculopathy, then we may have to immediately, because again, hypotony maculopathy is not a good thing to happen. It can end up in a scarring and can affect the vision of the patient. So we need to act really fast, either by forming the anterior chamber, or we may have to inject the helon or into the anterior chamber. Again, if the anterior chamber is shallow with hypotony, then if there are no other issues, again, you review the patient. If there is again an maculopathy which is getting involved, we have to act as quickly as possible by injecting helon. Now, if the anterior chamber is flat, we may have to go in and tie the tube and make sure that the flow happens at a little later stage. This can happen mainly with a non-valved thing, or non-valved GDD also. Now, this hypotonia or a shallow anterior chamber can be because of a choroidal effusion. Now, the choroidal effusion management is same like any other choroidal effusion, like in case of a trabeculectomy, what we do. So we can wait and watch, or we can give oral steroids, step up the topical steroids, start the patient on oral steroids. And if there is any kissing choroidals involved, then probably drainage of choroidal effusion may be required. Otherwise, it is always a medical management which we sought for a choroidal effusion in the beginning. Now, there can be a hyphema. Hyphema can be because when we are introducing the tube into the anterior chamber, it can hit the iris root. So it need not be always an NVI which can create a problem. It can be just the normal vessels at the iris root itself can cause bleeding. So when we introduce a tube, we have to be very, very careful. Again, if there are any kind of an iris vessels, which is there in NVIs, that can also result in hyphema. So there can be a leakage around the tube. So usually it is a 0.63 millimeter, and we introduce the tube using a 22 gauge needle. So when we introduce the needle and come out, please make sure that you are not making the that entry wider. So if there is any kind of entry, if the entry becomes wider, then there can be chances that there is a leakage around the tube. In that case, we may have to come out and suture that place and then put the entry of the tube into another site. Then the tube can get blocked by iris, vitreous, or cornea. Now, to prevent the tube blockage by the iris, as I showed you in the video, cut the tube bevel up. Okay. And in case if there is a blockage by iris, we may have to resort to an iridectomy, or we may have to remove the tube and reset the tube again. Now, another problem can happen when the tube can get blocked by vitreous. So it's important to look for any kind of a vitreous trans in the anterior chamber before you introduce, because I've seen sometimes when there is a post PKP cases, there can be some amount of remnant vitreous which is there. So before you introduce the tube into the anterior chamber, make sure that the anterior vitrectomy is done, or in case if the block happens post the surgery, we have to go back and do an anterior vitrectomy. Again, there can be a tube endothelial touch. So this is a patient who had undergone a trauma, RD surgery, SFIOL, and this is the trauma scar. And if you can see here, there is a tube corneal touch. So to prevent this kind of a tube corneal touch, we have to make sure that the entry of the tube into the anterior chamber the plane is parallel to the iris. Now, if such kind of a situation happens, and if you see that there is a progressive endothelial loss, we have to remove the tube. In this patient, I had removed the tube and I had put it into the pars plana because it was a vitrectomized eye. So you have to re-site the tube. You may have to trim the tube and see whether it will be away from the the corneal endothelium. There have been a lot of methods wherein they have used a Prolene suture inside the anterior chamber to keep the tube away from the endothelium. So there are multiple ways which we can use. And in case the tube has become short and then that has caused the endothelial touch, we can use something called a tube extender. I'll be showing you a picture of the tube extender wherein we can use that and make the tube again entry into the anterior chamber. Now, other complications which can happen is Delin. So because of the large anterior blebs, which can cause a tear film alteration, and that can cause Delin. And sometimes when there is a heaped up conjunctiva, there's a conjunctival suturing is not very good, then we can end up in having Delin. The main management is using a lot of lubricating drops. The important thing in Delin is please look for any kind of an infection, and you coordinate with your corneal consultant to get a good treatment for the Delin, especially if there is an infection which is involved. Rarely only the last resort will be to remove the implant in cases of Delin. Now, you can get malignant glaucoma also in these kind of patients. Now, how do we diagnose malignant glaucoma in a post-AGV eyes? So, you cannot resort to the PI patent and non-PI and all that, because we don't do any PI here. So, it should be a uniform shallow AC. The pressures can be normal or high intraocular pressure. So, if there is a shallow AC which is uniform with a normal or a high IOP without any kind of a posterior segment pathology, you have to rule out any kind of suprachoroidal hemorrhage, and then we can diagnose it as a malignant glaucoma. The management remains the same for any classic malignant glaucoma. I'm not going into the details of that. It is medical, laser, and the last resort will be a surgical management or vitrectomy. So this is a very important complication which we can get during a GDD surgery, that is called as hypertensive phase. Now, the definition of hypertensive phase is a little tricky. It is typically defined as an intraocular pressure which is more than 21 millimeter of mercury within the first 3 to 6 postoperative months. This I have taken the definition from Survey of Ophthalmology site, which is there, which is a recent thing which they have said. So I will still put it as little more earlier, even first month also it can happen. So it is not really 3 to 6 post-operative months. It can be even earlier. But only thing is that when the patient's pressures are more during the earlier days, we have to rule out whether the patient is a steroid responder. Again, the hypertensive phase can be a sign of early device failure also. Now, this hypertensive phase, Ayala has reported in his article that this is more common in AHMED implantation. He found that almost 40 to 80% of the case of AHMED implantation had hypertensive phase when compared to non-valve GDD like Barwell, which had only 20 to 30%, and a double plate Maltino also had somewhere around 20 to 30%. One second. Okay, so hypertensive phase it occurs basically due to the process of bleb encapsulation. Okay, so that's anyway an integral part of wound healing process which follows the device implantation. So how do we manage this hypertensive phase? So we have to give aqueous suppressants. So this is a study done in 2014 where they found an early aqueous suppressants could give this hypertensive phase a good treatment when compared to conventional treatment, that is without giving any kind of an aqueous suppressants. So 23.4% the IOP could be lowered using an aqueous suppressants. Again, one of the causes for hypertensive phase, again, it has been hypothesized as inflammation control. So in one of the studies, they have even pumped in anti-inflammatory drugs, even an oral anti-inflammatory drugs. But many of the patients had a lot of side effects. So they said that probably that may not be the right choice. Only pump in steroids and an anti-inflammatory topical drug can help us to alleviate this hypertensive phase. Now, in case of bleb encapsulation, we can sort to, if that is a reason for hypertensive phase, then we can sort to something called bleb revision can be done. Now, what are the late post-operative complications? So late post-operative complications include a tube or a plate exposure, tube retraction can happen, sometimes dysesthesia can happen, and as I mentioned, encapsulated bleb can happen at a later stage, strabismus and endophthalmitis. Now, coming to the tube exposure, now what are the ways that you can prevent this tube getting exposed? So as I showed in my video, I directly entered the anterior chamber. Now you can use a long needle track to enter it. And you can, as I mentioned that nowadays I'm using a small scleral flap And over that, I'm using a patch graft. So you have to use a patch graft, even if you sometimes use a long needle track, that can help to decrease the rates of tube exposure. Again, patch graft, you can use any of the tissues like sclera, cornea, or a donor pericardium. Again, another important cause for this tube exposure is micro motion of the tube. So that is why it is important to anchor the tube using a 2 or 3, sometimes mattress sutures, so that there is no movement of the tube. Now, Dr. Sunita Dubey from Shroff had given an article about the usage of capsule doxycycline in case of conjunctival erosion after glaucoma drainage. So even I use for patients who have multiple, conjunctival surgeries has been done, like retinal surgeries or failed trabeculectomy. These kind of patients, if we give capsule doxycycline orally, PD dose for 2 weeks, and then OD dose, we can continue for 4 weeks. That also helps to prevent in conjunctival erosion. And sometimes if there is an early erosion, it can help in a conjunctival reepithelialization also. So in case a tube exposure happens, so this is a picture which shows a tube exposure. So if that has happened, then we have to cover the tube with a patch donor graft, sclera or cornea or pericardium, and then you cover it with conjunctiva. So many times you can just undermine the conjunctiva from here, or you can use a pedicle graft from the adjacent conjunctiva. Either you can undermine the same conjunctiva if you think the conjunctiva is adequate, or you can use a pedicle conjunctival graft from the adjacent conjunctiva. And over and on top of the conjunctiva, we can use an amniotic membrane if it is required. So directly, we should not put an amniotic membrane. So it's preferable to use a conjunctival graft, and then over that, we can use a amniotic membrane. Now, when it comes to plate exposure, why does this plate exposure happen? So many times the plate exposure happens because of the loose suturing of the plate onto the sclera. So that is why when I was showing the video, I was reiterating that the plate anchoring onto the sclera is very important. We have to put firm sutures onto the sclera of the plate onto the sclera. So in case of any kind of a bare welt or an RD wings of the plate, it should be well placed behind the rectus muscles. And we should instruct the patient to avoid an excessive eye rubbing. Now, this is one of my cases where we had an plate exposure. Now, it is better many a time we can try to suture it, but it is better to many a time explant the AHMED or an RD implant in such kind of a situations. So in this study where they have done it in LVP, they have reported 6 cases. What they found is many of the patients are diabetes. That is one of the risk factor which they have found. And of course, if there is a recurrent surgery, and if we have done a surgery once, if it is a re-exposure of the plate, it is definitely better to explant. We can try probably as a first surgery to cover it with conjunctiva, or re-anchor the plate and then cover with a donor sclera and then conjunctiva. Basically redo the surgery. We can try that, but if the exposure happens again, then definitely it is better to explant the implant. Now, when it comes to tube retraction, so this tube retraction happens when there is, the insertion of the tube was of short length, or sometimes in case of congenital glaucoma or in children, when we are doing this GDD surgery, the growing eyeball can itself retract the tube. Or when there is an implant fixation which is not proper, it has got a posterior migration and the tube has retracted from the anterior chamber. In such situations, we can use this. This is called as tube extender. We can connect the tube extender and then redo the anchoring into the anterior chamber. So this is another complication which can happen with the plate bleb encapsulation when there is a poor flow control. As I mentioned earlier, it can happen in the early stage, or it can happen even in the later stage. Now, we can do something called needle revision. So this is a study which is done by Chen et al. Along with Dr. Paul Palmer. So they found that needling revision can be useful in management of GDD bleb. The same way we can use like a trabeculectomy needling revision. Now, this was another study where they had done something called decapsulation. So we can only go decapsulate the implant capsule and cut the capsule alone. Instead of just doing a needling revision, we can even decapsulate the valve around the fibrous capsule. So that also has given them a good result. So this is the way you can manage a bleb encapsulation. Some of the studies have shown that we can even use either a 5FU injection, like the way we do a trabeculectomy bleb revision, or some cases they have reported to have used a MMC also during a bleb revision. Now, dysesthesia, basically that is the irritation and constant tearing due to the large overhanging bleb. Basic management is lots of lubricating drops and reassuring the patient about the bleb. And yeah, that is the main management for dysesthesia. And when coming to strabismus, it is not very common. It can be, it can happen when we use a large plate GDDs, and rarely when there is an inadvertent anchoring of the implant to the extraocular muscles. Usually it is self-limiting strabismus which happens. Some of the cases they have given Fresnel presence, or rarely we have to resort to surgery to alleviate the symptom. The dreaded complication, yes, of course, it is endophthalmitis. This is a study which is published in British Journal of Ophthalmology, wherein they evaluated 542 eyes of 505 patients. In that, they found 1.7% of the eyes had endophthalmitis. Now, what they found is younger age and the conjunctival erosion was the common risk factors for when it was associated with endophthalmitis. Now, what are the organisms? Most common organism which they had isolated was Haemophilus influenzae and Streptococcus species. So sometimes the management of endophthalmitis, the usual management, and the last resort will be again, if there is any nidus of infection over the implant, we may have to explant the AHMED glaucoma valve or whichever implant which we have used it. So these are some of my book references, which I've used in my presentation, and of course the standard books of Bruce Shields and the Becker Scheffer. So I'll be happy to answer any questions which any of you have. Thank you.
Dr. Meena, thank you very much. It's been a wonderful talk. And
Thanks.
This actually, thank you. This is actually a very important topic for the DNB students and also those who are taking the FICO exam, because there's been a lot of renewed interest and increasing interest in the glaucoma drainage devices.
Yes.
I just leave it open so that we can take some questions. If anyone of you
Sure.
have some questions to ask Dr. Meena, please type it in the chat and we will take them as they come. There's been one question from Dr. Yash. Actually, you're able to see that, Dr. Meena? Dr. Yash Kala is asking, post PKP glaucoma, what would be indication to do tube procedure against micropulse laser?
See, micropulse laser is still not, very validated procedure. So definitely, I will prefer to do a GDD first, and then only the last option will be a micropulse laser. So micropulse lasers still come under cyclodestructive, even though it is not as cyclodestructive as the compared to the cyclophotocoagulation, but still I will prefer to go for a GDD, and then only last resort will be a micropulse. I think I can see some questions. Okay, antimetabolites. I think Priyanka has asked antimetabolites role in drop. So there is a lot of studies which is happening to use concurrent usage of antimetabolites along with AGV. So there have been they've been using at a lesser dosage. Personally, I have not been using an antimetabolites. Again, one factor which you have to be very careful when we use in these AHMED glaucoma valve implant patients are, again, as I said, these patients might have undergone multiple surgeries. So we have to be very, very careful when we use these antimetabolites also. And so that is one aspect of using antimetabolites. Personally, I have not been using antimetabolites in these kind of patients, but there are many surgeons who do use antimetabolites. But most of the surgeons, we don't use antimetabolites. Post-op, okay. Small, I think, yeah. Priming of the tube.
Meena, it will help if you read out the question because on the YouTube, they would not be able to see this.
Yeah, Dr. Kamla has given a tip on priming of the tube is preferably done before the conjunctival dissection should there be a malfunction of the valve. Yes, that's a real good tip. Personally, I always keep a standby because all these things, it is better to have a standby valve because there can be issues like this. It's a very, very rare malfunctioning can happen, but still, as we always keep a standby of an IOL, the same way I also keep a standby of valve so that, you know, no other mishap or you need not close it. So as she said, yeah, in case you don't have a standby and there is a malfunction of the valve, we can always postpone the surgery. So yes, it is a good tip that we can prime the valve before the conjunctival dissection. Can we, Dr. Ram Kumar is asking, can we take a bite through the tube wall to anchor it? No, there is an eyelet. I am not really understanding. There is an eyelet for the plate anchoring, and when you are see the one which I think what you are asking is the tube when we kind of put the scleral sutures are put. Now that is only to avoid a micro motion. It is not meant to be, you cannot put through the tube wall. You don't put, in a case of AHMED glaucoma valve, you definitely don't put through the tube wall. That is only to avoid a micro motion. So you just, take from sclera to sclera. Dr. Sriram has asked about the pars plana approach of the tube placement. How will the drainage of aqueous be met? So see, basically in case of when you are placing the tube onto the pars plana, you have to make sure that it is a vitrectomized eye. Basically, if already a vitrectomized eye, yes, it is much more easier. But if it is not a vitrectomized eye, sometimes when we are doing in case of post cornea surgeries or something, we are not able to see the tube and you want to put it in the pars plana, you have to make sure that there is a good vitrectomy which is done before we place the tube onto the pars plana. So it is going to drain from the pars plana. The tube which we put, it has to be of little good length. So many times when we do the indirect itself, we may be able to see the tube, especially in case of aphakic side. Doctor.
I'll just read it out. Dr. Ram Kumar is asking any pars plana approach in a vitrectomized eye.
Yeah, that's what. If it is a vitrectomized eye, I think we can, we can use a pars plana approach, but it's not a must that all the vitrectomized eye we should put in pars plana. Because if you see, if you go through a lot of studies wherein, pars plana versus an anterior chamber entry, you will be surprised to see that most of the anterior approach is much more successful than a pars plana. So unless and until you cannot put in an anterior chamber, then that's the time when you can do a pars plana. Yes, in a vitrectomized eyes, it is much more easier to put in a pars plana. In which cases?
From Dr.
Anumeha. Yes. Anumeha Priyadarshini is asked, in which cases will you prefer non-valved device over valve device? Little tricky, because in the sense, personally, I am not using a non-valve device as of now. Probably if you ask me, I'll put it like this right now. Why I want to use an RD many times is, I'm pretty convinced about the success of RD after seeing so many studies which have been done. Second is the cost factor. So it is a very cost-effective valve which is available right now for us, because many of our patients may not be able to afford an AHMED glaucoma valve. In such situations, definitely RD is a very good option which is there right now. So definitely I am in the path of using non-valved, that is the RD. I definitely want to use it because it is very, very effective and it's a very cost-effective device. Otherwise, medically, I don't think I will have any preference in any of the cases. Yes, very advanced cases, probably a valve is a safer bet when compared to a non-valve. But then if you see the success of bare weld implants also, they've been very, very successful non-valve device. So I don't think we can really compare the success in any specific cases. Yeah, Priyanka has asked, how long does a GDD work, and would only IOP and bleb morphology be a measure of functionality of GDD? Yes, definitely. That is the only way we can really understand whether the GDD is functioning, the IOP and the bleb morphology, as I said, if it's an encapsulated bleb or not. So how long? Yeah, like, I have cases where I've done almost 8-10 years. It is still working out. It might be a qualified success, like in the sense we may have to put additional medications even if we have put an implant. So I think qualified success has been pretty good. Post GDD, if you ask me, yes, recently we have performed 2 micropulse laser, because I just wanted to bring down the pressure still further. And sometimes we may have to bring down the number of medications. So I think it works quite well for many years. And what is the approximate, Dr. Swati wants to know what is the approximate length to be inserted in anterior chamber. So usually we can insert around 3 to 3.5 millimeter. Slightly longer if you are doing in a congenital glaucoma, because the tube retraction is more common. So probably you may have to put a little longer, and then you can little boldly put a longer tube in case of if the patient is a pseudophakic. But if the patient is phakic, 2.5 to 3, it's a good length which we have to insert into the anterior chamber. Again, when you are put if there is a long needle track, you have to count that as well. Dr. M.S. Ravindra sir has asked a role in pediatric glaucoma. Yes, there is a role. In fact, the role in pediatric glaucoma as a primary surgery is also gaining a lot of importance. But then personally, I don't perform as a primary surgery. I always prefer to do a trab on trab. And then once, probably a trab on trab and a repeat trab, if that fails, that's the time when I probably think in terms of a glaucoma drainage device. As a primary surgery, I am not really for it. But yes, there have been studies which are coming up, the GDD as a primary surgery in pediatric glaucoma. How do you minimize overfiltration in RD? Basically, while doing RD surgery or any kind of a non-valve surgery, it is the important part is the ligature of the tube. So as you saw in the video, the ligature of the tube has to be ensured by using saline, injecting the saline into the tube and seeing the backflow. So that is the only way we can make sure that the ligature of the tube is good. So that will help us to avoid the hypotony in cases of non-valved devices. Dr. Harsha has asked, how much of de-encapsulation would you consider if you take up case for resurgery? Is there an endpoint for de-encapsulation which we can look for intraoperatively? No, I don't think there is an endpoint actually. So when you do a needle revision, you definitely see, when you just do as a needle bleb revision, you will definitely see the shrinkage of the capsule which is happening, because it's more of the tense tenon cyst which we are doing. When you do a de-encapsulation, it is a thick capsule. It is a very, very thick capsule which is formed. So there is no real endpoint. We just, there is no real endpoint. So we just have to cut that thick capsule, part of the thick capsule which is there. And Dr. Priyanka has asked, when can a self-releasing ligature of the tube? Usually it gets released by around 4 to 6 weeks. 6 weeks is what usually it happens. Dr. Kavita has asked, what is the next option?
The question, Dr. Meena, is what is the next option if GDD is removed due to plate exposure, and if it's a repeat GDD done after a failed trap?
Okay, so basically once it is removed, due to the plate exposure, so if you go through that study which is done in LV Prasad, Dr. Sirisha's paper of 6 cases, so if you are like, what happens is many a time the IOP can get controlled by itself once the plate is removed. It can happen. Okay, so there is some kind of a drainage which is happening at the area of plate which you have removed. So if you are lucky, it happens like that. But I have been very unlucky with one of my patients whom I did a removal of the plate. So after that, it again shot up, the IOP again shot up. So we can do a GDD. In that paper also, they have done a repeat glaucoma drainage device on another site. So it again depends on the patient's consent as well, because many times patients are little skeptical about going for a repeat GDD. You can do again a repeat GDD if you want in another site. There has been a study where they have done 5 procedure. If you see a paper written by the glaucoma drainage success, one of the long follow-up, they have even done 5 surgeries like repeat GDD in inferotemporal quadrant. So you can do a repeat GDD. That is a possibility which is there if you do a remove the GDD after a plate exposure.
So the next question from YouTube is from Dr. Mohammed, who's asking, do you advise use of AGV as a primary treatment in FAK glaucoma in children?
Yeah, this is what I was talking, like, in children, in situations like this, you can still think an AGV as a primary option in glaucoma in aphakia or pseudophakia. Whereas in primary glaucoma, that is a congenital glaucoma, I will prefer to go with a trab on trab and probably a repeat trab and then think in terms of GDD. But yes, in glaucoma in aphakia is one of the indication of a primary AGV in children.
The next question is from Dr. Priyanka, who's asking, can GDD implantation be done topically with a corneal entry of the tube?
Yes, there has been a study which they have done a comparison of topical GDD with, in fact, GDD and topical anesthesia. But I am not very much for it, because in case if you are doing GDD in a person who have undergone a multiple surgeries, it is definitely painful, and many a time, in spite of doing a block, the patient, we keep putting the paracaine and proceed with the surgery. So total topical anesthesia, personally, I will not really suggest, but there is a study which is done under topical anesthesia. According to that study, they say that they could implant the GDD and the pain score was good and well tolerated by the patient. Personally, I will not really prefer to do it under topical anesthesia.
The next question again is from the YouTube stream from Dr. Preeti, who's asking, saying, as we are using allograft tissue to cover the implant, do we ever have to face with related complications? And if no, how are we saved?
There's also a continuation of the same question where she's asking what are the disadvantages and what bothers us in the usage of amniotic membrane. So I think it's all the same spectrum of the question.
So see, basically you can use an autograft, or rarely you can use an allograft. So that is from the other eye you have to use. So it is basically if there is a healthy conjunctiva, we should not have a problem. So it is the usual complications of conjunctival autograft or allograft which we have to think. And over and top of it, we can place an amniotic membrane. So that is more of a kind of coverage for the conjunctiva till it heals. Success rate of Dr. Divya has asked success rate of GDD in NVG. Yes, NVG, many a time we go as a primary procedure. As you saw in my video, that is a case of an NVG, which I have gone as a primary procedure, especially that patient was a one night. So definitely I didn't want to take a chance on a trabeculectomy and then wait to plan for a GDD. So that was a primary GDD in a case of NVG. Dr. Sri Shruti has asked a role of trab. Can you read out the question for me?
It is the role of trabeculectomy over a failed GDD.
Yes, again, see, once you do a GDD, again, once GDD fails, we always have this question, what next? So we can do either a trap. There is a role of trap. Yes, there have been studies which they have done after post GDD, failed GDD. There has been studies which they have done trap. Yes, there is definitely a role of trap. We can try a trap, or we can last, because especially when the patients who have a residual vision, it is important that we before we resort to any kind of a the spectrum of cyclodestructive procedures, we should try out all other kind of procedures. Yes, there is a role of trap in such situations. We only thing is that we have to make sure that we use a good site where the conjunctiva is mobile, and use of antimetabolites is a must, and a close follow-up. So the last resort will be a cyclodestructive procedures. There is a role of trap.
And the next question is from YouTube, Dr. Anumeha Priyadarshini. She's asking, do you prefer starting aqueous suppressant in post-op period in AGV surgery from first post-op day, or after a week or later?
Due to some technical glitch, we seem to have lost Dr. Meena's stream. So, Dr. Anumeha, we'll get that question answered to you and revert back. So, once again, a big thank you to all of you for logging in onto the session here today. We'll regroup again tomorrow at 12 o'clock, where we will have a talk on intravitreal injections by Dr. Madhukumar, who's our retinal consultant at Sankara Hospital in Guntur.